So good afternoon, everybody. I'll introduce myself. I'm Dr. Richard Chanik. I'm a pulmonologist at UCLA Medical Center as of 2 weeks ago. So I drove down here, which is nice. I was in Boston for many years at Mass General doing sort of the same thing, pulmonary hypertension. Been involved in the field for 30 years now, evaluating and treating patients with pulmonary hypertension. And I've really been able to see the whole evolution of this disease from one that was almost never recognized and everybody died of it to one for which we now have many approved therapies that are very effective. But of course, because we have so many options now for these patients, physicians at every level, primary care specialists, need to understand what we're talking about when we talk about pulmonary hypertension. It's not enough to just say this is a rare disease, I'm going to send it to a specialist. Because primary care physicians will see these patients and need to understand how someone like myself thinks about this condition, what I do to work up these patients, and then get some idea of how we pick what treatment for what patient. And to also really know some of the data by which we make those decisions about how we approach treatment to these patients now that we have so many effective treatments that really has dramatically changed the condition. These are disclosures and learning objectives. All right, so I'm going to go through what I consider the basics of pulmonary hypertension. So when we talk about pulmonary hypertension, you need to understand we're not talking about one condition or one disease. We're talking about a bunch of conditions and diseases. And this is really critical because how we treat pulmonary hypertension depends completely on what's causing it. And this is what we call the clinical classification system. So we developed this several years ago to try to group patients with pulmonary hypertension into 5 categories based on what was the mechanism of the pulmonary hypertension. We call this WHO groups, because the very first of these symposia we have every 5 years was sponsored by the World Health Organization. You have group 1, which is PAH, or pulmonary arterial hypertension, group 2, which is pulmonary hypertension due to left heart disease, group 3, which is due to lung disease, group 4, which is what we call chronic thromboembolic pulmonary hypertension, so patients who've had pulmonary emboli that haven't gone away, and then group 5 is sort of everything else. And you need to know at the outset that of all the patients you see or may hear about with pulmonary hypertension, 90% of them, before you know anything else, will be either groups 2 or 3. If you look at the conditions in each of those categories, these are very common conditions. Left heart disease, diastolic heart failure, COPD, interstitial lung disease, sleep apnea. Very common conditions that can lead to pulmonary hypertension. And again, I would underscore the point that pulmonary hypertension isn't one disease. In fact, it isn't even a disease, it's a number. It's elevated blood pressure in the lungs due to one of these conditions. The group for which we've developed therapies is group 1, which is pulmonary arterial hypertension. And these are a group of conditions that are much less common, but we still see, and you probably still see. We have idiopathic, which means we never find the cause. This is a rare disease, typically of young women. We have a genetic or heritable form, and then we have pulmonary arterial hypertension associated with drugs. So a lot of different legal and illegal drugs can cause the pulmonary vessels to get damaged, leading to high blood pressure in the lungs. And then a number of other systemic diseases like autoimmune diseases, like connective tissue disease, HIV, and you can see the list there, that can seem to cause pulmonary hypertension. But group 1, again, this is the group for which we really have developed the therapies. The groups 2 and 3, which again are much more common, are actually somewhat more challenging to treat other than treating the underlying condition. So very basic stuff about what we're talking about here. The pulmonary vasculature, and I don't know how many people are clinicians versus non-clinicians, but the pulmonary vasculature, which is supplied out of the right side of the heart, is typically has very low pressure in it. If you think about what the pulmonary blood vessels do, they allow blood to get through the lungs to exchange oxygen. And to do that, you have to have a very broad cross-sectional area. So the resistance to blood flow in the lungs should be very, very low. Someone used the analogy, if you laid out the lung with the vessels at a single cell level, it would cover a tennis court. I don't know how many people know that. So it's a huge cross-sectional area. And because of that, the right side of the heart, the right ventricle, never really has to do much. If you ever looked at a heart in a picture, the left ventricle is very muscular. It has to pump through your body against resistance, but the right ventricle doesn't have to do much because of that low resistance. That's great until there's a problem. And if the pressure builds up in the pulmonary artery for any number of reasons, the right ventricle is not well equipped to handle it. And so the right ventricle will fail. And so patients with pulmonary hypertension don't die of pulmonary hypertension, they die of right ventricular failure because of that inability of the right side of the heart to deal with that pressure. We won't go through a lot of equations here, but when we're thinking about the pulmonary vessels and the pulmonary vasculature, we have to think about the physiology as it relates to pressure, to the blood flow going through it, to the resistance. And we use this equation for pulmonary resistance. So when we work up a patient, we'll do a right heart catheterization to measure pulmonary artery pressure, measure pressure coming back to the left side of the heart, look at the difference in the pressure across the lung, divided by the cardiac output or the blood flow through the lungs, and we get what we call the resistance. And the pulmonary vascular resistance is probably one of the most important things that we look at. When we talk about the definition, so if I was to ask you, how do you actually define pulmonary hypertension? Like what number? I mean, you probably all know what high blood pressure is, what are the cutoffs. Well, we have it for pulmonary hypertension too, and the number is 25. And that's the mean pressure in the pulmonary artery. It's above 25, we consider that elevated. And that's based on studies looking at what are normal pulmonary artery pressures. We then define it even further because, as I said, it's not enough to know that the blood pressure in the lungs are elevated. You need to have to know where it's coming from. So, for instance, we can have the pressure coming from before the capillaries in the lungs. We call that precapillary, or it can be afterwards. And what I explain to patients is you can have a problem on the left side of your heart, which builds up pressure there, and then it backs up into the lungs. So you have high blood pressure in the lungs, but it's actually coming from the heart because it's a back pressure. And we call that postcapillary pulmonary hypertension. And we use some of these numbers to define pre- versus postcapillary pulmonary hypertension. And the workup then becomes very critical in trying to distinguish those and making a determination about treatment. So there'll be a quiz on this one at the end. You're going to have to draw it out for me. This is the diagnostic algorithm for working up a patient with pulmonary hypertension. And we'll go through that. It's actually not as complicated, and I'll talk about very basic principles. So the first thing is we need to suspect pulmonary hypertension before we can diagnose it. And as you'll hear, and one of the questions alluded to, the problem with pulmonary hypertension is often it's never thought of, because this is a disease or condition that can present in a very nonspecific way, where a patient can come to you just saying, I just can't do what I used to be able to do. I'm just getting more short of breath. I'm not sure why. I've been to a couple different doctors. They say, well, you're probably just... What I always say is the three things you never want to tell a patient as to why they can't breathe. You're getting older, you're overweight, or you're out of shape. All of those may be true, but you don't want to explain it that way without thinking about other conditions. And I can tell you that patients that we see sort of at the bottom of the funnel who have significant pulmonary hypertension have almost always been told one of those three things by some physician at some point before someone thought about the diagnosis. And in some cases, chalking it up to one of those three things can actually be fatal. So if you suspect pulmonary hypertension, you don't have an obvious explanation for somebody's symptoms of shortness of breath, exercise intolerance, you want to go through a basic workup. And the workup really, as shown on here, is thinking of the most common things first. So looking for other underlying heart conditions, looking at the lung function, looking for lung disease. Those are the most common causes of shortness of breath and pulmonary hypertension. And then depending if you find those or not, going on further with the workup. And that complicated algorithm really just reflects that classification system. So you want to just go down and think about each of these conditions and try to determine, does the patient fall into one of those categories? I'm not going to spend, because in the interest of time, we don't have a lot of time to talk, obviously, in detail about each of those conditions I mentioned. One that we're very interested in, and one that is even more of a problem, is group 4, which is chronic thromboembolic pulmonary hypertension, or CTEPH. And this is important because these are patients actually who can be cured with a procedure to remove these blood clots, something that we pioneered many years ago, to go in there and remove these clots that have been in there sometimes for years. So if a patient has a pulmonary embolism, and you all see that all the time, most of the time the clot will dissolve, even without any treatment, in fact. But in a percentage, a small percentage, maybe 2 to 3%, that doesn't happen. And it goes on to form scar tissue in the inside of the artery, which can lead to pulmonary hypertension. And there's no treatment that will remove that clot, or get rid of it, I should say, because it's really scar tissue other than surgery. Now, half of the time, these patients don't give a history of acute pulmonary embolism. They're simply coming to you saying, I'm short of breath. And you have to think about, could this patient have non-resolved pulmonary emboli from some point in the past to make that diagnosis? And we recommend a ventilation perfusion scan, shown here, to screen for that. This is a test that's been done for many, many years. It's a nuclear medicine test. And in a patient who has chronic pulmonary embolism, you'll almost always see what's shown on the bottom left there, perfusion defects, those white areas where there's no blood flow getting to parts of both of the lungs, versus other forms of pulmonary hypertension where the blood flow overall will be normal, because the disease in those patients is in the microscopic blood vessels. These are blockages in the larger arteries, and the lung scan will look like it does on that bottom left. So that's part of the workup as well. So we're looking for common heart disease, common lung diseases, and we're looking for unresolved pulmonary emboli. If you've ruled those out, then, and the patient you think has pulmonary hypertension, you then go on to right heart catheterization. So to make a diagnosis of pulmonary hypertension, you need an invasive test. You can't make a diagnosis non-invasively. An echocardiogram, which obviously very commonly used, which may suggest pulmonary hypertension, but you need to confirm it with a cath. And a right heart catheterization is a simple outpatient test that many cardiologists all can do, and it's simply measuring the pressures in the pulmonary artery directly, measuring what the heart output is so you can calculate resistance, and then excluding other things like other left heart diseases. So that's required to confirm a diagnosis. And what we always say is that you really should never treat a patient for pulmonary hypertension without a right heart catheterization. And I can't tell you the number of cases I've seen where that was not followed and it was a big problem. Because if you treat a patient for pulmonary hypertension who doesn't have pulmonary arterial hypertension, and you use one of the drugs that I'm going to describe to you, you can make that patient worse. And we see that time and time again. Okay, so that's sort of a very quick overview of the diagnostic approach. Again, for doctors who aren't subspecialists, the key is thinking about it, screening for it with an echocardiogram, and then doing some basic tests looking for common conditions. And then referring the patient to an expert who can finish the workup and make a determination about therapy. All right, so let's talk about what are the treatments we now have available for pulmonary arterial hypertension. We'll have plenty of time for questions, too, if you have them at the end here. So, again, I started doing this about 30 years ago. I know I don't look like I did this 30 years ago, but thank you. But but when I started this as a fellow, one could question why you would go into a field where there was no treatment. But I always found it very interesting. But I can remember, everybody died of pulmonary arterial hypertension. You had nothing to offer these patients. So fortunately, I've been able to get involved in developing and designing a lot of the studies that have led to these treatments. To now, in 2018, when we have 14 approved therapies, FDA-approved therapies for pulmonary arterial hypertension. So a pretty dramatic change since, the late 80s. When we talk about, and again, I'm not going to get into great detail about all the data with each of these drugs. I'll show you a little bit, because I think it is important that even if you may not be the one treating these patients, you understand a little bit about how these drugs got approved. The vast majority, in fact, all except one now, it's actually two because of a recent approval, but have been approved with one specific primary endpoint, and that was the ability of the drug to improve exercise capacity as measured by a 6-minute walk test. So that was the primary endpoint that led to approval. It's not showing an improvement in mortality, it's not showing other endpoints, but it's improving exercise capacity. And that's really been how the drugs have been studied and how we designed the trials early on. Now, these therapies do improve the hemodynamics. So if you treat a patient effectively, those pressures will come down, the resistance in those arteries will come down as well. But in pulmonary hypertension, drugs will never get approved based on their ability to lower the pressure. You have to have some sort of functional outcome or measure. What we say in the regulatory field is that the drug has to either improve how a patient feels, functions, or survives. That's the mantra for pulmonary hypertension. The other thing, though, that we know is that how much each drug approves a specific patient is very variable. And despite having done this for 30 years, I can still not predict in a given patient how they're going to respond to a given therapy. And so almost more important than what drug you start first is the follow-up and the ability to look at adding additional drugs, changing therapy, and you can only do that with experience. There actually is one of the 14 drugs that improves survival, has been shown, and it was actually the very first drug approved in 1996. And it was epoprostenol, which is a prostacyclin drug given as an infusion, a continuous infusion. So patients would have a Hickman catheter inserted and would have a pump and would mix up this medicine every day and walk around 24 hours a day with this infusion. It's a very effective treatment and one that we still use actually today, but it obviously involves a fair amount of work on the patient's part and is labor intensive. But that drug actually was shown to improve survival. So basic principles of treatment, as I mentioned, proper diagnosis to know you're treating the right patient, understanding the risk assessment, how sick is that patient in terms of what therapy they need, the close follow-up of the patients, and then the ability, which again is due to all these therapies, of having multiple therapies. So the concept of combination therapy for pulmonary hypertension is really becoming the norm and the standard of care now. And that's based on a number of studies, a few of which I'll show you, demonstrating the benefit of more than one drug in a patient with this condition. And how we use those combinations, do we use one after the other? Do we start everything at once, throw the kitchen sink at them, is debated. But we really do focus in many ways on the strategy of treatment for a patient, in some ways more than the specific drugs that we use. And that's, again, shown here in terms of getting a patient to feel or function better, being aggressive with treatment, individualizing it, maybe throwing everything at the patient, and then lung transplantation, although it's kind of at the end of the road, is still an option for treating pulmonary arterial hypertension in patients basically failing everything else. When I see a patient with pulmonary hypertension, I'm trying to determine what is the risk in that patient. These are some of the things we look at, and I won't go through these in detail, but how fast the disease is progressing, how poor the exercise capacity is on the walk test, what does the right ventricle look like on an echo, and what are some of the measurements we get on the cath. A high-risk patient we may treat differently than a lower-risk patient. This is just an overview of the options that we have. So on the left are sort of traditional or supportive therapies that have never been shown with randomized trials to improve anything in terms of outcome. On the right are all the FDA-approved therapies in 2018 for pulmonary arterial hypertension. And we group them into classes. So we have prostanoids, and these are substances that work through the prostacyclin pathway. Prostacyclin is a naturally occurring substance that dilates vessels. Your body produces it. But in pulmonary hypertension, it doesn't produce enough. So we can give it back either as an analog of the prostacyclin, or in the case of selexipag, you see there at the bottom, through activating one of the prostacyclin receptors, the IP receptor. Although the one person who got the answer right, I didn't have to tell you that. We then have endothelin receptor antagonists that block endothelin, so they block a bad substance called endothelin, which your body overproduces when you have pulmonary hypertension. And we have 3 approved drugs there that block that effect. We then have PDE5 inhibitors, which work on the nitric oxide pathway. Nitric oxide is good. And if you can augment that with either sildenafil or tadalafil, you can improve pulmonary hypertension. And then the last drug called riociguat also works through nitric oxide, but in a different way. So that's the list of drugs. And this is a nice little cartoon showing that these are what we call targeted therapies. And they work on one of those 3 pathways to improve the pulmonary vascular relaxation and prevent the thickening and the damage that occurs as a result of pulmonary hypertension. So it's a really nice example of the development of drugs specifically targeted to abnormalities in the pulmonary vessels. And I'm going to skip through this or go through this very, very quickly, but again, we're determining risk, low, intermediate, or high risk, and making a determination as to how they treat these patients. Patients who are high risk, we're going to be more aggressive with than patients who are lower risk. But even patients who are lower risk need aggressive treatment. Just a few slides on the clinical trials. We can spend obviously hours and hours, but again, having been involved in all of these from day one, we can see the evolution and how we used to test these drugs. So all those on the top were short-term studies with smaller patients where we looked at exercise capacity, as I mentioned. So a patient would get the drug or placebo. You would do a 6-minute walk test, hall walk. How far can you walk up and down a hall in 6 minutes, before and at the end? And you were able to show the drug versus placebo improved the 6-minute walk distance. But it became clear that we needed to show more with these drugs, especially as we got more and more therapies. And those bottom 3 studies are what we call morbidity mortality studies. And these are much longer studies with much larger number of patients where we're really looking at the ability of the drug over a long period of time to prevent some sort of clinical worsening. It could be worsening exercise capacity, could be hospitalization, death, need for additional therapies. This is what we call morbidity mortality or event-driven studies. And the last 3 studies that we published were all in that category. And so I think those have been very important. I'll just show you a couple very quickly in the last few minutes. This is macitentan. So this is one of the endothelin receptor antagonists. And this gives you a little taste of what the kind of way we study these drugs now. So this was the endpoint that we were looking at. It's what we call a combined morbidity mortality endpoint. So if the patient had any one of those things occur, on the left there, that counted as an event. And that would be the end of the treatment arm, placebo arm, treatment arm for that patient. And that's how we did these studies. And what we're able to show with macitentan in the slide here is that patients who got macitentan at the approved dose of 10 milligrams had a significant reduction in the likelihood of having one of those bad events happening. And that reduction was in the range of a 45% risk reduction. So pretty impressive. And that happened, and this, again, we're not going to get into great detail, this occurred even in patients who were already on another drug. So about 2/3 of patients in that study were on sildenafil, Viagra, as their background drug. And then they were randomized to the macitentan or placebo. And even in patients on background therapy, like shown on the left there, you still had a benefit. And again, that's an inkling of why we're talking about combination therapy. This was another recent study, selexipag. So again, the prostacyclin receptor agonist. And very similarly, we looked at a combination endpoint of disease progression, hospitalization, death, need for additional therapies. And we're able to show similarly that patients who got the selexipag, which again is the prostacyclin analog or agonist, we had about a risk reduction of about 40%. So it has a ratio of 0.6. So I think a lot of people put 40%, so that was good. In terms of the likelihood of an event. One thing about this that you should note is that 80% of the patients in this study were on background therapy. And 1/3 of the patients were actually on 2 background therapies. They were on one of the endothelin receptor antagonists and a PDE5 inhibitor. So even in patients on 2 background drugs, the third drug seemed to prevent or decrease the likelihood of worsening. So again, that's very important information. Now, the question then becomes, well, if we're able to show that one drug on top of another seems to get a benefit, why don't we just use drugs together up front? And we can debate that. There's clearly an ability, obviously, to look at those 3 targets, those 3 classes of drugs, and say, well, we're going to treat each of them at the same time. There's one study that's done that called the Ambition study. This is with a different endothelin receptor antagonist, Ambrisentan, and a PD-5 inhibitor, Tadalafil. And we're able to show that in patients who got both of those drugs up front, there was a similar improvement in the clinical endpoint, that event, morbidity mortality endpoint, compared to patients who got one drug, either or. It was a pooled monotherapy. So the combination up front seemed to improve patients' care to single therapy. And that is becoming more the norm now with data like these showing that, well, maybe it's not enough just to start one treatment. Maybe we should start 2 up front. And some people are even suggesting 3. But we need data on these. And I think clearly, we can debate it, but they're clearly, I think, taking the individualized approach. Maybe low-risk patients start 1 drug, more higher-risk patients start 2 drugs. And then there's some uncontrolled reports on triple combination up front. So we have guidelines to help guide strategy for treating pulmonary hypertension. These are more recent European guidelines that bring up that idea of initial oral combination therapy in higher risk patients. And we've just recently met for another one of these every 5-year symposia, and that will become a pretty strong recommendation for the majority of patients is upfront combination therapy for pulmonary hypertension. Now, these drugs aren't without any downside, and all these drugs have some side effects. You give a vasodilating drug, you're going to get flushing, headache, you get some GI symptoms, and so you need to understand those before you prescribe them. And there are some drug interactions that you should know. We'll talk a little bit more in a second, or the speaker, about when to refer, so the issue of access to specialists. But clearly, as I mentioned, I think once you've ruled out very common things, you need to send to a specialist who can work up the patient. And there's some emerging endpoints looking at sort of non-invasively right ventricular function. We think quality of life is obviously very important. And we have some data that with several of these therapies, patients' quality of life can improve dramatically. So very quick overview, but in conclusion, pulmonary hypertension can occur in a variety of conditions. You need to understand that, and a variety of different patients. The approach to diagnosis needs to be followed systematically to avoid misdiagnosis, and not just under-treatment, but over-treatment, or what we might call mistreatment. And we do have numerous treatment options now, but clearly expert evaluation and treatment is required, given what I think you got a taste of, some of the complexities in dealing with this under-recognized condition. So I think I'll stop there, and thank you for your attention, and we'll move on to the next speaker. Thank you.
Hi, everyone. My name is Megan Santana. I am the Director of Practice Optimization at a primary care office called Rittner Medical Associates in South Philadelphia. A little bit about our office. We are involved in many quality programs. We do CPC+. We are a PCMH recognized practice. So to us, care managing patients and developing processes is part of our daily workflow. Today we're going to be talking about delay in diagnosis and why that's devastating to a patient. One of the first things I want to talk about is it's an estimated 2 years between the onset of symptoms to diagnosis, and you're kind of asking yourself, why does it take that long? Well, if you work in primary care and experience your patient population, many times you have patients that come in for episodic care. They don't have that incrementalized care where they come in and they see you frequently and talk about all of their symptoms. You have patients that specifically just go to a specialist and don't really come to primary care, so that's another avenue of why it would take longer. Or, our favorite patients, the ones that go to the ER when they have symptoms and don't come back to the office. They only go to the ER when they have symptoms. So all of these things can impact their diagnosis. Most commonly, when it is in primary care, it's presented as dyspnea on exertion, which could lead to a plethora of different diagnoses. It could be misdiagnosed, just as Dr. Chanik was talking about. And this is so devastating to patients because their mortality rate increases the longer it takes them to be diagnosed. So it's very important to kind of think about this and recognize it when you're seeing patients and think about pulmonary hypertension. So what does the data tell us? The data tells us that there's an inverse relationship between socioeconomic status and disease severity. So kind of, if you think about it, in our healthcare system today, many patients have their healthcare tied to an insurance or tied to an employment insurance. And why that's so important is because if you're earning money, you are employed, you have better access to a healthcare plan, you may have more access to specialists, you may have a broader network, whereas if you are unable to work because your symptoms become so severe, you may be forced to take Medicaid or have no insurance, and your access diminishes greatly. And many patients that we experience in our office are Medicaid patients, or they are unable to work because of their symptoms. So you're left with, how do I treat this patient? There's a quote from one of the articles that I was reading when researching this, and it says, socioeconomic status plays a vital role in access to health care, and our results indicate a significant delay in diagnosis in patients with low socioeconomic status, as evidenced by more severe symptoms of functional limitation at the time of initial diagnosis. So this is really important to kind of identify them early on and try and get them help. So there was a study done by Actelion, and they looked at the impact of pH on patients. And what they found is they looked at 4 different areas: the physical and practical environment, the emotional impact, social impact, and informational needs. And what they found was they had a great physical impact, that nearly half of these patients could no longer work, which meant that they didn't have incomes. I mean, if you think about your patients and you think about a patient who was the primary breadwinner of the family that can no longer work, it's devastating. They can no longer afford to go to specialists or pay for medications. 1/3 of their caregivers were impacted with their adverse work schedules. So, thinking about the downward effects of it, one of the most interesting things that I found that many of the patients were very candid and open about was it affected their sex lives, that they could no longer be intimate with their partners, and how that affected them. It made them more depressed. It made them feel socially isolated. When they were short of breath, they could no longer participate in social activities with their friends because they just felt so exhausted that they couldn't participate in it. So it's really not just one impact, but it impacts many parts of their lives. So I thought that was a really interesting study. Here's something that's always very interesting. Well, these patients need a specialist, so how accessible is it? So what I did was I looked at pulmonary specialists across the nation, and this is from the CDC. And what I found was there's less than 1% of pulmonologists across the country, compared to about 13% of primary care physicians. So clearly there's an access issue. There's not a lot of pulmonologists. And what I also looked at was, you can see there's a color variation of states from mortality rates for pulmonary hypertension. And what I did was I looked at all of the states that had the highest mortality rate. And what I found was very interesting. So I circled South Carolina because I'm going to use it as an example. But when I looked at Oregon, there's only 47 pulmonologists across the state. In Idaho, there's 25. In Vermont, which is red, there's only 11 pulmonologists in the entire state. And if you think about how many pulmonary issues that patients can have, that's not a lot to serve a patient population of states that have 4 million, 6 million people. So I looked at South Carolina, and I wanted to use this example. They actually had 71 pulmonologists, which was on the higher side of things. And I took Manning, South Carolina. If anyone's from Manning, please let us know if there's a pulmonologist there. But I used Manning, South Carolina. It was kind of in the middle of the state, and I kind of used it just as an example. And I said, if a patient has pulmonary hypertension, what would it be like to get to a specialist? And keep in mind, if they have pulmonary hypertension, many times they're on oxygen. So if patients are traveling at a minimum of the shortest time at 52 minutes, typical oxygen tanks cover about 3 hours. So an hour there, an hour back, you have to park, walk to the specialist's office. They may not be on time, and your visit may be longer than an hour. What do? Do you bring a big oxygen tank? Do you bring 2? And these patients can't breathe to begin with, so carrying extra weight is really difficult for these patients. So thinking about just from an access standpoint and all of the other effects that come from that, it's really difficult to manage these patients. In South Carolina, like I said, there's only 71 pulmonologists. And when I looked at this number, I kind of questioned it. And what I found is that's licensed professionals. So you could hold a license in South Carolina but not practice there. So this number could be inflated, so there could be even more of an access issue. And if I tried to lay out the statistics here, so that's 1.43 pulmonologists per 100,000 people. And if you think about wait times for getting a specialist appointment, that's significant. You can wait months to see a pulmonologist, and those months are very critical with patients with pulmonary hypertension. So now that I've laid out that kind of dismal picture for you about access, I'm going to try and explain some solutions and some possible ways to do some care management for these patients. So I like to think about everything that could go wrong and what you can kind of do to plan for that. So assessing barriers to care. Look at your patient population, look at your location, and find specialists or subspecialists that handle these patients. So your pulmonologists in your area, how far are they from your office? Try and build a relationship with them, outreach to them. In our office, we try and build relationships with many specialists, and the way that we do it is I usually outreach to that office, and I make a relationship with an administrator in that office so they know they can call me if they need something, and I can call them if I need something. So it's having that administrative relationship, but then also having a physician-to-physician relationship so they can talk about the patient, make a plan for it so they're on the same page. They're not ordering duplicative testing. They're all on the same page. And that's kind of the ideal gold standard of what we try and do. Making that co-management agreement also include the patient in it so they know who to call and when to call. That's very, very important. The more that the patient understands and the more that the patient knows how to reach people is your ideal state. So I have to have a nod to Dr. Gawande at Mass Gen. He always talks about a checklist manifesto, and I think that checklists are very successful, so I created a checklist for this. And it's really generalizable to any specialist that you refer to, and it's kind of blurred here, and we're going to go through the questions. But it's thinking about your patients when you refer them to specialists, thinking about all of the aspects of their care socially outside of the office that could impact them, and kind of trying to identify them and have a working plan just in case an inevitable bad problem happens. So if you look at this, the first thing we're going to talk about is the access. So what's the distance they have to specialists? We kind of talked about this in the South Carolina example. How far do they have to travel? Is it at a university where they have to walk a really long haul to get there? Do they have a clearly defined map of where to go, what building to go into, what suite number it is? Having all that information for the patient is very valuable so they get to the appointment. If they get frustrated, they may wind up not going to the appointment, and that doesn't service anyone. Thinking if someone can accompany them to the appointment, whether it's a family member, whether it's someone from their insurance plan that can come with them, that can understand what's going on and can help the patient. A second set of ears is always very helpful to patients. Thinking about, does the patient require oxygen? Thinking about the implications of that. Can they do stairs? What's their availability to walk a distance? All of these things, kind of walking through with the patient and setting realistic expectations with them are all really important when referring to a specialist. And then paying a copay. We have this problem with our patients. Sometimes they don't want to wait to see a specialist, or sometimes they can't afford the specialist copay, so they will use the ER as their method of seeking care. So kind of asking them that question up front and talking to the specialist's office and trying to make arrangements for that can be really critical. We had a patient that we tried to set up to go to a specialist's office about 7 times, and she no-showed 7 times to this office. I'm amazed that they would still book another appointment with her. But we found out that she didn't want to walk upstairs. She didn't want to do any stairs. She wanted to be able to walk in the building on the first floor. And she had a lot of transportation issues, but we wouldn't know that unless we asked the questions to her. So it's important to kind of get their social situation. Talking about their social environment. Do they live in an older house? In our area, if you need to have transportation come to your house that's arranged, that's, through the Corporation of Aging or something, they won't come and get you in your apartment that's on the 2nd floor. You have to be able to meet them at the curb. So is that going to be an issue walking down the stairs? What if they're a fall risk? Kind of thinking about all of the different aspects of how they can get to the transportation. Do they have familial support, or are they alone? Do they have anyone that they can help, or have a friend that lives down the hall, that's a caregiver to them? Thinking about the resources that they have available to them and working with that. And if they live alone, trying to develop a relationship with maybe an insurance company that they can have telephonic monitoring when they can't come into the office. The next one's patient status. So this one's talking about does the patient really understand what pulmonary hypertension is? The more that they understand, the more that they can engage themselves in their care. It's not just, are they literate, as in can they read, but are they health literate? Do they understand the medications that they're taking, what the side effects could be, and kind of what to do with their comorbidities with their condition? Language barrier is always interesting. It's not always how you say it, but it's also if they speak a different language, how are they really understanding, and how do you know that they're understanding their care plan? So kind of thinking about that beforehand. This is something that we put on the worksheet for our patients. We did this also with asthma and the COPD worksheet, and it's kind of laying out what they're feeling, what they should do when they're feeling the way that they are, who they should call, when they should go to the emergency room, and kind of having the important numbers right there. So they have a clear plan. When I have shortness of breath, this is what I do. It's better for them to have an action plan and can be able to follow a grid. That way they're not left to question, and when they question, they can sometimes utilize care inappropriately. So it's trying to avoid that. Here's some potential roadblocks that we see very frequently. So they use the ER a lot. So it's trying to have that meaningful conversation, using the plan, redirecting them back to primary care or to their specialist for frequent follow-ups. That's very, very important. Having same-day appointments that are available for these patients. Flag them as high risk. Tell them that, they have same-day appointments. Tell them when they are. Have the after-hours number plastered everywhere in your office so they know that they can reach you and feel comfortable. If a patient's homebound, try and find them a physician that goes to the office or goes to their home, seeing if they're a part of a community and seeing that if that, church or community partnership will make house calls and go and see them, refer them to home care, have someone come into the house and be the eyes and the ears, even if it's a caregiver that calls and gives updates, have some sort of connection to be able to care manage them. And then this is another big one in primary care. It's medication cost. So investigate. There's PACE that's for elderly or Medicaid. It's in every state. Try and getting them enrolled in those programs. Contacting pharma. A lot of times they have programs that can help patients pay for medications because, remember, these patients don't just have pulmonary hypertension. They could have a plethora of other conditions. They're on polypharmacy. Each of these drugs, even if they're $5 a piece, can't afford $50 a month for medication. So it's kind of thinking about solutions and being creative in the way that you approach it. And then finally, evaluating for generic alternatives is an important one. Okay. Does anyone have questions? No? All right. Well, thank you.
Yeah.